So whenever you think about interstitial nephritis, think about drugs, because they constitute about 70 to 75% cases of interstitial nephritis. Think about all the drugs, whatever the patient is on. If you do not remember the side effect, I would suggest you to search the side effect at Google or whatever the source you are using, because sometimes you'll be surprised. So number one, I look for antibiotic. Penicillin, cephalosporin, beta-lactam antibiotic, fluoroquinolone, sulfonamide, rifampin. After antibiotic, number one, I look for antibiotic. Number two, I look NSAID, PPI. And then diuretics. So I mentioned the medication in red. These are the ones we mostly use in the hospital a lot. These are the common medication we use. Lasix, Bumax, cimetidine, antacids, antibiotic we are using all the time. And right after these three classes of antibiotic, I look for infections. 4 to 10% of the cases. Pyelonephritis, UTI, Legionella, leptospirosis, CMV. Rest are rare, but pyelonephritis is most common. And if I couldn't find anything, then I look for systemic causes, which are 10 to 20%. I start multiple myeloma workup, SLE, Sjogren syndrome, sarcoidosis. So what are the clinical signs and symptoms? As you see, non-specific. So they will have kidney injury, but signs and symptoms will be non-specific. Malaise, nausea, vomiting, they can have. So I know, like, we all read about fever, rash, eosinophilia when we were in med school and when we were preparing for USMLE exam, but this is present in only 10% of the cases. Only 10%. Fever, rash, eosinophilia. So even one of these is present, you should consider possibility of interstitial nephritis. How to make a diagnosis? Kidney number will be high, elevated creatinine. Patient can have eosinophilia on CBC, eosinophiliuria on urine analysis. We can look at urine sediment. It will be non-specific. They can have proteinuria, hematuria, RBC cast, white cell cast. It's not very specific. NSAID-induced acute interstitial nephritis. So patient will have history of NSAID. Treatment is discontinue offending agent. There is no definitive evidence that corticosteroid therapy is beneficial, but sometimes I always see that nephrology is putting the patient on prednisone, low dose, to see if the patient is respond or not for 1 to 2 weeks. So you can try that. Chronic interstitial nephritis. Again, I'll start looking at the drugs. All the drugs patients are taking, pain meds, chemotherapy, marijuana abuse, systemic diseases. I will do ultrasound of the kidney to see if the patient has any obstruction, and then multiple myeloma workup.